Today, I'm going to talk about the role of community in the particular context of health system strengthening in Bangladesh. In fact, Ministry of Health and Family Welfare in Bangladesh has established 13,500 community clinics throughout the country. These clinics have been built on the lands donated by the community, and the government has recruited, deployed, and trained one community healthcare provider for each of these 13,500 community clinics. These clinics are managed by our community groups of community representatives. And of course, these are supported by community support groups of men and women. In this ecological model, where the government is seeing the households as part of the larger health systems, is a fundamental shift in paradigm, where the households and the role of the community is seen as an integral and inherent part of the health systems. Let's start with the households. This is a community health workers who are plenty in Bangladesh and recruited. These community health workers are recruited by government as well as by the NGOs. The lady on the right who is teaching a household member, a recently delivered woman, how to take care of the newborn. These locally recruited community health workers are counseling and educating the families and providing them with supplies and skills necessary to take care of the mother and the newborns. This lady in the middle is not a community health worker. She is rather a traditional birth attendant, a family member who has just learned from her community health worker how to take care of the newborns. This is an example of transfer of skills from the community to the community. This lady you are seeing is not in her jeans or not putting on a life jacket, but she is crossing bridges like that every day. And in that process, she is becoming a bridge between the health systems and the community. Without people like her, the unreachable couldn't be reached. The households are of course part of the community. And when we say community, it's nothing but collection of households coming together. Now when they come together, the strength of the collectiveness is unlimited. They learn how to take responsibilities, and they also learn how to help each other. And in the area that we are talking about, a northeastern part of Bangladesh, a district called Hobiganj, where we have been working with 4,000 community support groups. And these support groups actually have their own representatives, a network of community volunteers, and about 12,000 of them who we'll be talking about. This is a community support group where the community members, every month they come together and they discuss their own health problems. They identify their own health problems and they find out solution to locally manageable health issues. These community support groups are managed and facilitated by their own representatives, the community volunteers, and they use locally developed tools like hand-drawn maps to find out who in that community are left out of the services. These groups are very diversified and also inclusive. These groups are male groups, there are female groups, there are mixed groups. This is the example of the changing Bangladesh, and clearly in these groups the hype and the message is very clear: to reach out to help and to reach out to seek help. This is an example of a community transport system, and these transport systems take mothers and newborns who are sick to the referral care centers. Often these referral services are owned by the community support groups and managed by the community volunteers. This is an example where a community volunteer is painting a Ministry of Health community clinic. This is a very simple task, but the message is very clear. It is the sense of responsibility, the sense of ownership that this is our clinic. We have talked about households and the communities, but what is more important is to talk about the interaction between these entities. Without this interaction, without making sure that these different entities are interfacing within, the institutionalization process of the community inputs cannot be ensured. As we have talked about, every month the households and the community members come together in a community support groups. In that community support groups, they send their own representatives, the community volunteers. These community volunteers meet the community health workers of the government as well as of the NGOs. And this is an innovation of the project that we are talking about. This is the community micro planning system. Why it is micro? Because it looks after the small catchment area all eligible couple, all pregnant women, the mothers and the children, to find out whether they are receiving the services properly and in full. And these meetings actually check the status of each of the mothers and the children. They update the information in the health management information system, and to make sure that all the vulnerables who live in the outskirts of the society are being reached with services. And what is more important, through this interaction, an informal accountability system is developed. Every month, the service provider is meeting the service recipient, and this relationship is not antagonistic. This is very much amicable. A win-win situation is maintained. Through this micro-planning system, a monthly action plan is developed, which then goes to two different places, to the sub-district manager of the Ministry of Health and also to the local government ministry. And they then take it to the health systems to ensure that these identified health systems are solved. Health systems problems are solved. This is a photograph of a typical community micro-planning meeting, where the gentleman in the white shirt is meeting a group of community volunteers who come from different sections of the community. This is a local government health and family welfare standing committee meeting, where the problems identified to different community micro-planning meeting are being discussed in order to find out the appropriate solutions. Now the question is, all these meetings, interactions and exchanges, do this result into something tangible? Yes. In one fine morning, in one of the localities, one of the community representatives have mobilized about 400 community volunteers and community people to build this access road. This access road has been built by the own resources of the local government ministry to reach the health center that you can see at the far right corner. This is more serious. Like they have done in the case of community clinics, community has donated 1/3 acres of land to build about 7 3-storied building clinics in very remote rural areas of Hobbiganj. Now somewhat the buzzword of partnership has come to very reality in this area, where community participation, government participation through technical support and overall supervision, human resource, and of course the partnership and funding from the different private sector sources have become together to make sure that the health system service delivery is ensured for these remote rural areas. Now the big question, the so what question, is it working? Is it really reaching the people's life? Is it changing the health systems? Is it changing the status of the health of people? Yes. This chart shows the time trend of last 1 year of the mothers and newborn, very complicated mothers and newborn who are reaching at the referral facilities. Nothing to explain. This simple time trend shows that the utilization of the referral care center is increasing day by day. This chart shows the proportion of recently delivered women who has received antenatal care in that particular district. And we can see between 2010 and 2012, between 18 months, overall the increase was by 6 percentage points. Now when we broke it down by sub-districts, we found that in the 4 most hard to reach sub-districts, the increase was even higher, about 11 percentage points. This is how the community participation actually results into reducing the geographical inequity. This is an example and chart of several very key MNH, maternal and newborn healthcare interventions: contraceptive prevalence rate, antenatal care by medically trained providers, and consumption of iron folate tablets, facility delivery, and so on. Everywhere you can see a consistent increase in the coverage of these very essential interventions. Like for example, in the contraceptive prevalence rate of modern methods, we can see about 1/5 participation and contribution was by the community volunteers who referred the clients for long-acting and permanent method contraception. We counted for maternal deaths. In 2012, there were about 116 maternal deaths, which came down to 87 in 2013. We then projected the maternal mortality ratio, which came down from 217 per 100,000 live birth to 160 per 1,000 live birth. And compared to the baseline, this is way too low, which was 425 from a nationally representative survey from that particular region. So what is the lesson learned? It's very simple. If you can use the huge potential of the community, if you can unleash that, that is a significant tool and approach to strengthen the health systems. One more thing, When you look at the health systems, you have to use two lenses, two perspectives. One is from the top, using the WHO 6 building blocks, and using the same building blocks, you have to look at the health systems from the bottom, from the districts, from the service delivery perspective. If you don't do both, you're going to miss the better half of the health systems. Thank you.